Thank you, Emily, and welcome to this teleconference. All of the, I guess, listening audience, I should say. We do have a fairly heavy agenda, and this talk is prepared in a very clinically relevant manner. Although there is a significant component of this talk that's based on contemporary scientific developments or conceptual developments that do affect how the MS field is going to evolve. And then in the second part of this talk, I will be talking specifically about the emerging therapies, which obviously are very relevant to our practices, our research, and however we want to take a look at it. And of course, this becomes even more so interesting since we've just had another clinical trial data released literally as of yesterday. That's September 30th. So without further ado, I'll start with this first topic of vitamin D. And of course, I, from a Times perspective, put out one of the most significant papers that came out earlier this summer in June in Brain, which is a very prestigious journal, as you may all know. And during this, in this particular paper, and there are several references in this paper, the point that I'm trying to make is that the vitamin D as an immunomodulating therapy is a concept that's now being tested in several clinical trials. Previously, as we may expect, most of the times vitamins considered a generally healthy substance if taken in adequate doses is a well-accepted concept, but here we are talking about something a little bit different. This is a vitamin which has distinct immunomodulatory properties, causing an anti-inflammatory milieu or a so-called Th1 to Th2 shift, and also downregulating some of the inflammatory cell population or inflammatory cytokine-producing cell population, including IL-17. And so if one removes the topic or the title of this paper, in my opinion, as one goes through it, it's very evident that vitamin D could be potentially a disease-modifying therapy if the clinical trials as they evolve are successful. With that said, the next slide is sort of a few bullet points on the fact that vitamin D is converted into an active metabolite after exposure to sun or dietary intake, and it does go through 2 hydroxylations and eventually becomes the active metabolite, which is what exerts the immunomodulatory effects. And of course, exposure and seasonal variations also tend to be a big variable, as well as the color of the skin. Nonetheless, it does have a bit of a lagging effect. So peak summer and peak winter, there's a little bit of delay when the levels are at the highest and lowest. And there is emerging data, as pointed out in this paper, that keeping the vitamin D levels above a certain level, even within the very normal range of 30 to 80 nanomoles per liter, keeping it higher, particularly above 50 and 75 nanomoles per liter, has more immunomodulatory effects. And sometimes that can be achieved in doses of 3,000 units a day, and in some patients it might take more. This is a very individualized response, and there are now several clinical trials looking at fairly high doses of vitamin D, even between 10 and 50,000 units a day, which is something that I do not recommend we do at this point, but lower doses and keeping levels in that range where it may exert immunomodulatory effects might be something to look into practice, because at lower doses, for the most part, vitamin D is fairly well tolerated with little to no side effects, and of course it's quite cheap as well. The B-cell story continues to evolve in multiple sclerosis. It's something that has taken more and more significance in the last 2 or 3 years, since we had one major clinical trial telling us that it has probably a very distinct role and a very promising effect in MS patients. And this particular slide, the role of B cells in MS, is a mere reminder of the immunologic effects of B cells in the immune compartment, not necessarily just restricted into becoming plasma cells and making antibodies, but it has a number of things, including, I think the last two bullet points on this slide are extremely important because they have a direct relevance with the rituximab relapsing remitting trial. One is the crosstalk with T cells, and the second is antigenic presentation. And I'll quickly refer to those as we get into that particular slide and the data set.